Welcome to Trio, Maryland, the virtual transplant journey of 2022. And we look forward to a program filled with great information and takeaways for everyone participating. To open the event, please welcome Marty Marin, the president and co-founder of Trio Maryland.
Good morning and welcome to Trio Maryland's second virtual transplant conference. We are so excited that you are joining us today for this educational event. I am Marty Marin, president and co-founder of the Maryland chapter of Trio, which stands for Transplant Recipients International Organization. I am a liver recipient from November 2009 at the Johns Hopkins Hospital, and I am very thankful for my second chance at life. After my transplant, I became a volunteer at Johns Hopkins Hospital and the Living Legacy Foundation of Maryland. And then we started working on establishing a Maryland chapter for Trio. Our mission is to connect transplant recipients with one another, to provide information on transplant topics, and by offering non-clinical support, we complement the services of healthcare professionals. During the last 9 years, we have offered over 100 monthly educational meetings. We have hosted 5 in-person conferences and last year's virtual conference. Transplantation is a journey, and our conference brings you topics and information to help you navigate this new stage of your life. Trio Maryland is a nonprofit 501c3 organization founded and managed by transplant recipients. We continue to offer great events due to the generosity of our members and friends. With your financial support, Trio Maryland will continue to provide timely and educational information to the transplant community. Let's take a few minutes for some thank yous. I would like to thank the Trio Maryland Board of Directors and Ashton Conference Planning Professionals, our web hosting company, for all that they did to create this event. I would like to thank our partners, the Living Legacy Foundation of Maryland, Johns Hopkins Hospital, and the University of Maryland Medical Center. I also want to thank all the presenters for their time and for sharing their expertise on these important transplant topics and for sacrificing their Saturday morning for us. We have wonderful sponsors that are involved in this transplant community, and we wouldn't be here today without their support. Thank you to our sponsors that have helped with this year's virtual conference: Trio National, Biloxis, Anatomy Gift Registry, Peak Relief, and the National Kidney Foundation of Maryland and Delaware. Don't forget to check out our sponsors and their websites for details on their products and services that they offer. You'll find them on the sponsor tab on the registration platform. Thank you again, and we hope today's informative, educational, and helpful as you make your transplant journey.
Thank you to Marty for that, and a great way to start off our 2022 event. Trio Maryland is excited to be bringing you this conference virtually. And a quick reminder about your individual schedule. Please remember that the sessions for which you registered all will have separate Zoom links. You can log into the links 5 minutes before the session starts. And if you need any support, please text 301-452-6548. The first session today is preparing for your heart and lung transplant. Any questions and answers, please post your questions in the Q&A tab, and we will share with the speaker after the presentation as time allows. We have 2 speakers today, Gina Pace and Deb Carter of the Johns Hopkins Hospital. Gina is currently the lung transplant coordinator at JHH Comprehensive Transplant Center and is an active Trio board member. Deb Carter is the lead nurse practitioner with the Heart Transplant and Mechanical Circulatory Support Program at JAH and has over 40 years of nursing experience. Please welcome Gina and Deb. Thank you. Please take it away.
Thank you, David. Good morning, everyone. Well, this is a new experience for me. We've done a lot of Zoom meetings over the last 3 years, but presenting over Zoom. So it's a little bit challenging, but I will do my best. So we're here this morning to talk a little bit about preparing for your heart and lung transplant I'm going to start off talking to you about heart transplantation. Oh, a little bit of a problem. Hold on one second. Gina. Here it is. Okay. First of all, some of the indications for heart transplant is are that you have reached the point where you're at end stage heart disease and your disease process is not amenable to other medical or surgical therapy. Generally, patients are exhibiting class 3 to 4 heart failure symptoms, and prognosis for survival is generally only 50 to 75% to survive less than a year. And you have to have demonstrated poor performance on a metabolic stress test. The different diseases that lead to end-stage heart disease include congenital heart diseases, ischemic cardiomyopathy, non-ischemic cardiomyopathy, which encompasses both familial and idiopathic, valvular heart disease, and then people that have developed refractory ventricular arrhythmias. Some of the questions we usually get are what would make me potentially not a candidate for heart transplant. Generally speaking, we don't transplant patients for heart transplant if you're over the age of 70. If you currently have an active infection, given the fact that the medications you have to take post-transplant could actually make the infection worse and become overwhelming. If you have a diagnosis of severe pulmonary hypertension and that cannot be reduced with medications, if we transplant somebody that has high pressures in their lungs, the new heart would fail immediately. If you've had a blood clot to your lungs, it's another reason recently we have to wait a certain time period before you would be eligible for transplant. If your body mass index is greater than 38, we've just recently changed that, so I apologize for the error on the slide. Our current guidelines are greater than 38. If you have a history or are currently using tobacco or any other illicit illegal substance, you have to be abstinent for about 6 months. If you are cachectic, where you have poor nutritional status, would also be a problem because it would delay healing post-surgery. Cancer is evaluated on a case-by-case basis, depending on how long it's been since your cancer has occurred and if you are considered cured. Any other major systemic illness would potentially be a contraindication to heart transplant. If you are diabetic with end organ disease. And another area that becomes problematic is if you don't have good social or financial support. Our social services, we try very hard to look at all avenues to help you from a financial perspective, looking at insurances and other options that may be available. This is a very difficult journey that you're undertaking when you go through transplantation. And so it's really important you have a support system that can help you along the way. Major psychiatric illnesses have to be able to be managed safely post-transplant. And then if you have a history of being non-compliant or non-adherent to the recommendations for your medical therapy, that may also preclude you from moving on to transplantation. So how do you start this process? First of all, you have to have met the requirements that I just outlined. Having end-stage heart disease that's not amenable to any other medical or surgical therapy. And you can either be referred by your cardiologist or some patients actually refer themselves. Heart transplantation and left ventricular assist device evaluations may occur simultaneously. Some patients require assist devices prior to transplantation. The heart transplant office will ask the finance office to get financial clearance for you to undergo an evaluation. So the financial clearance is actually a two-step process. And this is the case for all organ transplants generally. We have to check your insurance to see if you are cleared to undergo an evaluation at Johns Hopkins Hospital where we work, but any facility where you're referred to would have to check to see if your insurance is accepted at that facility. Once you've been cleared for an evaluation, you go through the evaluation process, which is a lot of testing and meeting with the transplant team. You would be presented at a multidisciplinary meeting, and then we have to send all of that information to the insurance company a second time to get the final authorization to actually activate somebody on a transplant waiting list. What kinds of things do you undergo when you go through a heart transplant evaluation? You meet in an evaluation clinic with a cardiologist, transplant cardiologist, transplant nurse coordinator, a social worker, nutritionist, a financial counselor, and also a cardiac surgeon. Various tests are done. There are CAT scans that are required, possibly metabolic stress tests, echocardiograms, a right heart cath, occasionally a left heart catheterization, ultrasounds of your carotid arteries, and pulmonary function tests. Depending on what is found and your age, you may also be required to undergo further testing. There are multiple laboratory studies that we require. I've listed them on the screen. You want to make sure your health maintenance is up to date. Are you up to date with your colonoscopy, mammograms, pap smears, prostate testing, and also dental? Dental is very important, and you are required to have dental clearance prior to getting activated. And again, we may have to do additional studies based on the results of the evaluation studies that we do. So what is your responsibility? We're going to look at each phase of transplantation. You want to schedule your initial visit. You will be scheduled during the evaluation phase in the evaluation clinic, as I indicated, to meet with all the team members for heart transplant and or for left ventricular assist device evaluation. You will have the teaching done, the initial teaching in the evaluation clinic. During that visit, you must sign, it's required, an evaluation consent prior to any of the other testing being done. This evaluation tells you about the process again, but also lets you know that at any time during the process, you can say, I don't want to proceed further. But we cannot proceed with scheduling testing until the consent has been signed. We will perform a chart review also to determine any other testing that's needed based on your age and your health history. And that's all based on our evaluation protocols. We'll schedule the necessary testing as an outpatient, and the goal is to complete your outpatient evaluations within 4 to 6 weeks. If unfortunately some of our heart transplant patients, or many of them, are in the hospital for heart failure at the time, and our goal to complete the evaluations while you're inpatient is 2 to 3 days. Once all the testing is completed, we have a selection committee that meets once a week. It includes all of the transplant team members, the transplant coordinators, cardiologists, surgeons, nutritionists, social workers. It's a very large group. It includes everything, and we review all of the evaluation testing and to determine if you would be a good, acceptable transplant candidate medically before moving forward with listing. Once the determination is made that you would be a good transplant candidate, we send all of that information off to the insurance company so that we could get the authorization to go ahead and list you. Once you are approved by the insurance as well, that is the time you actually get listed on the transplant list. Once you are listed, you will receive a letter that you've been activated on the UNOS transplant wait list, which UNOS stands for the United Network for Organ Sharing. United Network for Organ Sharing is the organization that manages the national wait list for all organ transplants. It's a nonprofit organization that was established back in 1984. And the membership includes general public health or general public members, voluntary health organizations, all the transplant hospitals and organ procurement organizations. If you look at the map, the purpose of UNOSIT was established to facilitate that every organ transplant in the to facilitate all the organ transplants in the United States and ensure that the organs are procured and distributed in a fair and timely manner. In Maryland falls, you can see on this map, in the area of Region 2. All the organs have different listing criteria. I'm sorry for this, the smallness of this picture. However, it's just to show you, it's very detailed for, this is just a pocket reminder for us of the various statuses and the requirements. We had in the heart transplant realm, new status criteria became effective in October of 2018. We used to have about 3 statuses on a transplant list. We now have 6 statuses that are active, with status 1 being the most critical. Organs are allocated to the most critically ill patients in a 500-mile radius. And in Region 2, I can tell you currently in the heart program, generally speaking, patients have to be status 1 or 2, and sometimes a status 3, and rarely a status 4. 5 and 6 statuses generally have not been called in for transplant. They're fairly far down on the list. And I just wanted to go over some of the things that you need to keep in mind once you are on the transplant waiting list. It's very important that you continue to have your follow-up visits at least every 3 months with the transplant cardiologist and clinic. We need to keep our transplant office updated with changes in your medical conditions, such as weight, phone numbers, and definitely insurance changes. We often have patients that their insurance has changed and we call them in for transplant, but we don't have authorization with their new insurance. So this is very, very important during that process. It's also important for you to know that you can list it at multiple centers if your insurance will allow it. It's really, really important that you continue to study information regarding post-transplant care during this pre-transplant phase. And please feel free to ask questions of your transplant team members. It's really important you have a lot of information that you need to absorb in post-transplant early on. It's very difficult when you're also trying to recover from surgery. If available, we have virtual support group meetings for the heart transplant patients. I think it was very helpful for patients that are waiting to be able to talk to people that have been through the process. And you need to be prepared if you're going to undergo heart transplantation that you're going to have to be admitted to wait for the transplant. It would really be nice if we could just go to a shelf and pick a heart, but we don't have that. This is a very limited resource. Heart transplantation is matched by blood type and body size. We're talking a little bit about the surgical phase. It's done through a median sternotomy, which is an incision down the center of your chest. And the donor heart has to be transplanted within 4 to 6 hours. And they primarily, this is just a picture of how the donor heart is sewed in. During the post-operative phase, generally speaking, patients are in the intensive care unit for 2 to 4 days, hospitalized for 10 to 14 days. And these things are all based on whether you have any complications or not. During that time period, you are getting some teaching about medications, exercise, diet. However, as I recently mentioned, it's a very difficult time and retention is very hard, we like to include your family member or primary caregiver in any of the teaching that's done during that process. This is why you really need a lot of support in the post-transplant phase. And just quickly, a little bit of the differences. Once you have a heart transplant, the transplant itself is your heart no longer has nerve innervation. So your resting heart rate normally is generally between 90 and 110, and that is normal in a person that's undergone heart transplantation. You have to remember to change your positions more slowly. If you're getting up out of bed, to sit on the side of the bed for a couple of minutes, because your body doesn't have the nerve innervation to increase the heart rate and keep your blood pressure up. So it's possible people have actually passed out from changing positions too quickly. You need to warm up and cool down with exercise. So these are important things that you need to learn following your transplant. And I just put this picture up. These are only, there are 3 mainstay drugs that most organ transplants are on, especially early on. Tacrolimus, Cellcept, or mycophenolate is the other name, and prednisone. I don't want to go into detail this morning about all the various side effects and drugs, but patients will often come to clinic and tell me, well, you know, it's the pink pill, but this is an illustration just that we don't want you to know what color the pill is as much as we want you to know the name and the milligrams that you're taking. As you can see, the top portion of this picture here, this is all one medication, different size pills, but these are all the generics. And as you can see, they come in various colors. So you cannot rely on colors to tell people to figure out your medications. So very, very important that you learn the name of the medication, particularly the medicines that you take to prevent rejection. Very difficult. I tell patients you're really trading one set of circumstances for another going forward. And it's really important that you spend a lot of time learning the medications, knowing what you're on, and give yourself a good 6 months before you start feeling back. You'll be doing more, but until you really start feeling back to yourself, to give yourself that much time during the recovery process. And from a heart transplant perspective, weekly visits for heart biopsies and clinic visits occur. You have to have frequent labs. We recommend cardiac rehab after 12 weeks. We've kind of pushed that off a little bit during the prime COVID phase of things as well to limit your exposure to other people. However, now we're getting back more with having patients start rehab after 12 weeks. You have a lot of medication adjustments. We do a lot over the phone based on your blood work. It's important to write those changes down. And you want to monitor for side effects of the medicines, potential infections and rejections. And stay in close contact with your team. I cannot stress this enough. It's very important, especially early post-transplant and even longer after transplant. Don't stay home and say, oh, is just a sniffle, especially these days. Just a sniffle can end up being COVID. So very important to stay in close touch with the team. As they say, it takes a village to raise your children. It takes a village to really help transplant recipients through this journey. This is a group of just our heart transplant, inpatient, outpatient, ventricular assist device, and heart transplant coordinators, our office staff, and this does not include the cardiologists, the surgeons, all the social workers, and everyone else that is involved. Our goal is to help you get back and have a good quality of life, to do all the things you want to do. And with that, I'm going to turn it over to Gina, my colleague.
Good morning, everybody. Deb and I have worked together for many, many years, so this felt very, very comfortable to share the session with her. Thank you, Deb. You did a great job. You're very comprehensive on preparing for heart. I will say that lung is very similar, but there are some differences that I'm going to highlight as we go along, and hopefully wouldn't be too redundant with what she has already talked about. Okay, so, lung transplantation, when we are looking at transplanting our patients, we have to make sure that they've been diagnosed with particular diseases that we know are end stage and that there's no further medical management that's going to work. A lot of times, our patients are requiring so much oxygen at rest that they have a very, very hard time just doing activities of daily living. They have multiple hospitalizations, probably somewhere between 2 and 4 in a rolling year. Their pulmonary function has declined steadily over the last several months. They retain a lot of CO2. They also, just in general, their quality of life has really gone downhill, just to get up every day and take a shower and walk up steps and try to make a light meal becomes pretty difficult without a lot of oxygen support. The main leading diseases that we are transplanting for are COPD, that also includes alpha-1 antitrypsin deficiency, which mocks COPD, interstitial pulmonary fibrosis, interstitial lung disease, cystic fibrosis with bronchiectasis, pulmonary hypertension, and sarcoidosis, to name a few. There's other ones, but these are the major ones. So again, just like with heart transplant, when we are evaluating you for a lung transplant, we have to make sure that we are not going to compromise you getting a successful transplant and actually seeing it all the way through. So we have to make sure that you aren't smoking, you haven't smoked for at least 6 months. There's no substance abuse. We also have increased our age limit. We will entertain patients upwards of 73, 74, 75, but they have to be in very good, your health has to be in very, very good condition other than your lungs. If you have a lot of coronary disease, your heart would just be too strained to actually survive the operation. Any kind of bone marrow dysfunction, if you have a major psychiatric illness that, the medical management of that would compromise or the medicines that you would need to take for transplant. If you're extremely deconditioned, this is a really, really important one. In order to successfully get through a transplant, you have to be strong. You have to be able to walk into this operation already being able to complete some ADLs with oxygen, but you're moving, you're doing things. You're not, you haven't been sitting and become so weak and debilitated that you can't move. You would have a really difficult time rehabilitating after transplant. If you've had any previous chest surgery, that always complicates a successful outcome. Just getting in there to get the lungs out would be difficult. Echolalia, what that means is a swallowing problem. A lot of times, pulmonary diseases and esophageal dysfunction go hand in hand. If you have a lot of esophageal issues, anything that you swallow could have the potential of coming back up and going up and over and down into the lung area, compromising those new healthy lungs. That would be very detrimental. The only thing you want to see go back down into those new lungs is air and nothing else. All of your other organs, your bone density, again, like Deb had said, you have to have social support, financial support to make that through. You have to not already have other sort of infections that would also compromise a good outcome. And many times people can have a smidget of a little of this, a little of that when it comes to these potential contraindications. And that's where our multidisciplinary team would determine how much risk we could take on that would still, we would be hopeful for a good outcome. Our lung transplant evaluation, very similar to heart. It's a comprehensive head to toe. We just have to make sure that, you know, your body can withstand the stress of surgery and that you can withstand the stress of the medications after transplant for life. We do all the blood work the same. We do all the health maintenance exams, such as Pap mammodental, you know, colon screening. We do all the scans, and we do a complete cardiac workup as well. And again, the swallowing studies, I can't stress that enough. That is so, so important. We do 6-minute walk testing. That determines just how deconditioned you are and how we can help you get a little bit more conditioned, whether it's needing more oxygen and pulmonary rehab, things like that. And of course, all the consultations with nutrition, with thoracic surgery, with the social worker. There's a complete 1 to 2 hour teaching session with the coordinator, that's my primary role, just really teaching you and getting you to understand the breadth of this process, to make it as easy as possible so you have all the information in front of you to make decisions along the way. If we come to the conclusion from our multidisciplinary team that this is something that we can offer that we think will be successful, we would put you on the transplant list. And by doing so, we take all of that testing criteria and we put it into a formula. And the formula then gives us a score. The score is your lung allocation score. Could be anywhere from 0 to 100. 0, you don't need a transplant, and 100, you needed it yesterday. Most people, when they get placed on a transplant list, they're sick enough to wait, but not too sick. And that means their score typically falls somewhere in the 30s and 40s. What that means is that's about the middle of the transplant list. It's sort of in the 50th percentile range. That means about 50% are sicker than you, and you're sicker than 50% that are already on the list. The listing score will change. This is something that we will periodically be assessing in clinic. We do updated pulmonary function tests. We take a look at your 6-minute walk test and some of your labs and how much oxygen you're using. And we will change that lung allocation score according to your condition. So as you get sicker, your lung allocation score gets higher. As the lung allocation score gets higher, you move up on the list, and transplant is closer. We also go out into the region too, like Deb had said, with the heart transplant. But we also, if you draw a circle and you go out about 350 miles from our center, and that would be how it would be in any other center around the regions, we will go that far to find donors and bring them back. Your blood type is very, very important in how quick you get a transplant. O is very common, AB is very rare. And then also the lung size. Size is very, very important. So like a shoe size. When we put new lungs in you, they have to match the size of the chest that we've taken it out. We can't put little ones in, and we can't put too big of ones in. They have to be your size. The transplant surgery, unlike heart, we have options sometimes. Sometimes we only need to transplant 1 lung, not 2. In that case, we do a single thoracotomy, which is just sort of around the one side of the body of the area that we're going to explant and implant, or we do a double lung transplant and we do a clamshell incision, which goes right underneath of the lower part of the chest. It depends on your diagnosis as to which option you could have. Some people can get a single or a double. Some it's safer or more appropriate to do just a single. Some of the diseases that are firm on double transplants are sarcoidosis, cystic fibrosis, and pulmonary hypertension. You must have doubles. other diseases such as COPD, we could do a single as well. And just on a little side note, you only need one lung to breathe. Typically, you don't need two. One will supply 100% of the oxygen requirement that the body needs. So that's sort of a nice advantage. As same with like the heart transplants, when you are recovering from lung transplant, it's going to be very, very important to get up and move. Mobility is very, very important. Coughing and deep breathing. You will be taught by a post-lung transplant coordinator who will go over how to monitor yourself safely at home for signs and symptoms of rejection or infection. This is something that you're trading off by getting new lungs or a new organ, because you're always going to be more susceptible because you're immunosuppressed, meaning you're taking on medications that suppress your immune system so that your body doesn't fight these new lungs, because your body is always going to know that these aren't your lungs, but we have to make it friendly. So we lower your immune system, we give you medication safely, we titrate and wean them forever, and we need your help at home to surveil, to monitor for how well your immune system is handling these new lungs. Very simple, but necessary testing, such as checking your blood pressure, checking your heart rate, checking your temperature, weighing yourself, and writing things down and reporting them back to the transplant coordinator so that they can monitor and also adjust your medications as needed. The first year is the most tenuous and fluctuating because your body is healing and growing and working with these new lungs. But it's a teamwork effort. It has to be done so that if things aren't working out, we can change your medications around so that these lungs work well for you. After you go home, you will have to come back and forth constantly to be monitored in our clinic setting as well. We need to monitor your pulmonary function tests. These pulmonary function tests are very valuable. It lets us know if there's any dysfunction with those brand new lungs. And it is the goal that when we transplant new lungs in you, that your lung function will actually improve upwards to 9 months after getting a transplant. So that's pretty super good, that you will feel great right after transplant with these new lungs and you can breathe. But the thought that you actually will even breathe better and feel better upwards of 9 months later is pretty incredible. But we monitor your pulmonary function tests. We make you go to pulmonary rehab to exercise those new lungs because you've kind of deteriorated prior to going into transplant. And now we want to get you back up to your fighting weight. We want to get your sea legs back. We want you to really feel good and be able to go out there and do the things you want to do and be completely active in your life. We will again continue to monitor your medications and titrate and wean them. Personally, everyone's a little bit individual. We start out cookie cutter with the same 10 to 14 different medications, and then we wean them down to the lower doses as possible to meet your needs. Some of the things, like I've already hinted on, we're always looking for chronic rejection. That is sort of like your body's own immune system constantly trying to work against those lungs. But if we do our job and we work well with you together, with you monitoring home and us monitoring you at the hospital, we will find that perfect balance of medications to keep that at bay. Some of the other things that we look for is Bronchiolitis Obliterans, and that is basically like sort of a low chronic rejection, which this is something that can happen 1 or 2 years after transplant, or it could take 7, 10, 15 years out. Everybody's immune system and everybody's lung transplant is different, but it's one of those things that we're always looking for so we can medically manage it. Restrictive allograft syndrome is something that would happen pretty much right after transplant. Don't see that much anymore. Malignancy, when you have an immune system that is suppressed, anybody across the board, like your body can't fight the normal risks of cancer. So things like skin cancer, the sun, everyone knows that you're supposed to wear sunscreen across the board. Anyone getting a lot of sun exposure, burned skin, has an increased risk of skin cancer. But as a transplant recipient, your immune system is suppressed. You're sort of 10 times more susceptible to getting that same skin cancer. So slathering up with the lotion, putting on a hat, sitting under an umbrella, enjoying the beach is more appropriate. PTLD is post lymphatic disease, and that is a type of cancer that goes through the lymph system. Again, we're surveilling for it. We know that that's a risk out there, but it's one of the risks we're willing to take to offer you life with lung transplant. These are some of our recipients from lung transplant that have gone out and lived their lives. Actually, there's a heart transplant candidate there as well. There is life after transplant, and that's what we're here for. That's our goal. That's what my goal has always been. I've been in transplant world for over 20 years, and transplant is a great option for many people, and it's worth it when you can see that you've given back their life and they've gone out and lived it, whether that was, getting married or, raising their children or seeing their grandchildren or taking their trips, because you can travel, you can go back to work, whatever you want to do. So it's pretty super important to us that we can see that happen. Oh, I think that's it. So that ends our session between heart and lung transplant, but we welcome questions out there. We can answer anything for you.
Well, I can say there is one question here in the chat, and it says basically, what can we do to help patients prepare themselves for post-transplant recovery, such as preparing their home or doing leg strengthening exercise, how, informing them how difficult it is to get out of bed, etc. How can we increase that line of communication so that patients are maybe a little bit more aware?
So I can speak from lung, and then I'll hand that question over to Deb from heart. From a lung transplant perspective, we want you to be in a clean environment, smoke-free. We do not want you living in a house with smokers. They should be outside the home. When we think about, and from a lung perspective, you have to remember, we give you these new lungs, but you're always going to communicate with the environment. We're breathing every day. So, you will have to wear masks after transplant. When you go out in public, you will have to wear masks if someone within your home gets sick. That does happen. We get colds. It's not a perfect world with that. So you have to wear a mask intermittently there. When you think about where your incision is, we think about the water that we're washing ourselves with. The shower heads in some homes, who knows how long you've had those shower heads. If you've been in a home for a long time and you've never changed that shower head, it may be a good thing to do, just because there are potential mold and things like that in the plumbing that you want to avoid. As far as drinking water, we tend to let our patients know that drinking water, bottled water, is better. If you have a well system, it needs to be checked so that it is safe and there's no organisms in the well that need to be filtered out. When I think about where you sleep, you want new pillows, not old pillows with a new cover on it, but new pillows. You breathed on those forever. It's time to get a new favorite pillow. A new clean mattress cover. you can use the same mattress, but a new clean mattress cover, new super duper toothbrush, new one. They're the old one out. That has all your old germs on it. And if you have a basement or you have a damp area in your house, to make sure that it has been assessed that there is no mold in those areas, and it be repaired and cleaned up before coming back home to recover.
Mhm.
Deb, can you think
Yeah.
of anything
No,
else with
in terms of staying, sorry, I was coughing, so I wanted to put a mask back on. In terms of staying healthy, in terms of staying active for at least heart transplant, and I think lung transplant as well, to try and stay as active as you're capable of being, walking is always a good thing to do. The problem with heart transplant recipients is the majority of people that need heart transplant end up waiting in the hospital. So our goal is to keep you walking on the units to stay as healthy as possible and to keep your endurance at a level that'll help you in the post phase. That's not always doable depending on how ill someone is. But even now we're using support devices that are they used to only be accessible via the groin. Now they're accessible under the arm in the axillary region, and we get people out of bed and walking with those in as well. So that's really important. And good nutrition is important. So those are some of the things, and I agree with Gina. We've had to have, patients have had mold in their house, so they've had to have some mold remediation done prior to discharge. So making sure your home doesn't have mold is really important. And just making sure all your health maintenance stuff is up to date. That's really important. I can't tell you how many people, and I understand because some insurances don't cover dental care and it's expensive, but infections in your teeth can seed the valves in the heart. And people don't always think about that, but it's really important. And we're putting you on medicines that suppress your immune system, that make you more susceptible to infection post-transplant. So you have to have good dental care and make sure your dentition is safe going into transplant. I don't remember, did we answer all the aspects of that, or do you have a follow-up question?
There is another question that has popped in to the chat, and it's specifically for heart transplants. How has the increase in BMI from 35 to 38 affected supply and demand?
It doesn't really affect the supply and demand. It affects on who gets activated on the wait list. I can't really say that it's increased the number of transplants that we do. But as you know, that tends to be a problem. It's difficult for patients that are ill to keep weight off sometimes. I know with lung transplant patients, they're on a lot more prednisone. Generally, heart transplants aren't. And that increases people's appetites, but a lot of transplant recipients have weight issues. They can't exercise, because they get short of breath, or they're just, and it's a problem. It's helped a little bit in terms of patients being eligible to get listed for transplant, but I can't really say it's changed the number of transplants we've done.
Yeah, I would echo that with lung as well. It might make a few more candidates that are
Make you eligible
more
to get
eligibility,
listed.
right?
And generally speaking, most programs, I just was talking to University of Chicago, and they will not budge off of a BMI of 35. Because statistically, patients that the more overweight you are, there's more complications post-transplant. So,
Right, wound
and
healing and getting up and being able to move is so important.
yeah,
Right. Mhm.
so, but it hasn't changed the supply. Because we're not looking at it from the donor perspective size, we're looking at it the recipient size. So it doesn't really affect the supply of organs. Pretty much the transplant numbers have stayed pretty static across the United States in terms of heart transplantation. I've done transplant for 30 years now, and it's stayed pretty static in the total number of transplants that are being done per year, unfortunately.
I'd like to go back and touch on other ways to prepare for transplant. And I guess I should really emphasize this, the amount of support you need. You cannot do this alone. And only having one person to support you is not nearly as much. It's not that we need you to have someone that's a nurse at home taking care of you. That's not it at all. When you come home from a transplant, you're able to walk, you're able to go up steps, you're able to take a shower by yourself, you're able to probably make a light meal, but you need a lot of help making sure that you do the other pieces of taking care of yourself, making sure that where you live is cleaned up. They're going to the grocery store for you. They're coming and taking you back and forth to the clinic. They're taking you back and forth to your pulmonary rehab 3 days a week. They're taking you to the lab to get your lab drawn, or maybe they have to go back and pick up a new prescription that we've changed. The amount of running back and forth and just making sure you do those tests every morning, doing your breathing test, making sure you weighed yourself, making sure you ate, making sure you're not sitting and growing roots on the sofa. Maybe that person also has to come every time to the appointments to tattle on you, not in a bad way, but you tend to, as a patient, report how you feel because you don't want to bother someone, or I'll feel better tomorrow, or yeah, I'm eating, but you're really not eating. But your loved one who's there seeing you say, no, I can't even get them to eat toast. Or, no, they're really not getting up and moving like you told us he's supposed to. They kind of like to sit and take 4 naps a day. I mean, it's all to make you better, and it's human nature to feel how after a transplant that you want to go home and just curl up and be comfortable in your bed or whatever. But we know that the goal and to get up and moving and healing, and everyone needs motivation, and you need more than one person because the care provider is going to get exhausted. You need several people. This one can take me here, and this one can do this part for me, while this person, they can stay home and they love to cook for me. But the care provider needs help too. But it's all hands on deck. And then once you're healed and once you're feeling better, which usually is about 3 or 4 months, and then you'll be independent again. You're going to be able to do everything by yourself. You can drive, you can do all, and your appointments stretch out, and then you're where you're supposed to be at that point. But if we don't get that care and that coordination of help during the most needed time, it's going to be hard for you to do well.
And I think from a heart perspective, there is a difference in the length of time people are able to get around and do more. I think lung transplant is a little bit longer than heart transplant. At least in my experience, I've kind of worked with both. I think lung transplants are a little bit longer post, but heart transplant recipients still can have a rough go of it, especially now because so many are having assist devices and going into transplant. It's changed over the years. So it really depends patient to patient, but emotional support post-transplant through this phase is really important, which is why you need a good support system. Also, you've gone through a lot, your family goes through a lot. And so, we're here with different resources that you need. but you have to let us know what's going on, because we can't help you if we don't know what's going on. So I can't, that's why I stress staying in touch with your team. But again, I agree with Gina, the support that you need post-transplant is so important. It's important while you're waiting. Just this whole process. And please, please remember, your family's going through it too. You're going through it physically and emotionally, but they're also going through it. So we need to offer you as much support as we can for both the caregivers and recipients. And that's what we're here to help you with as well.
Thank you. Next question is, if weight is a factor, a risk factor, considered to be a risk factor for transplants, does that mean that generally healthier patients must wait longer?
Say that again, sorry.
If weight is considered to be a risk factor, does that mean that healthier patients must wait longer for transplants?
Healthier patients, and if their weight is too high and they're healthier, I guess I'm a little confused. I will say, given the allocation system, the way it currently is, patients generally, from a heart perspective, are sicker going into transplant than in the past. It's not just weight, however. It's a lot of factors that play into that. So we're not transplanting patients that are super healthy, obviously, for obvious reasons, but or they wouldn't need a transplant. So I'm a little confused by the question, I think. I don't know. Do you agree?
Right. No, healthier patients aren't waiting longer. I mean,
No.
you know, once you're on the transplant list, whether it's for heart or lung,
It's based on your status.
right, right.
And
Your
whether the match
status.
comes up based on your blood type and body size
Mhm.
for hearts, and same for lungs,
Size for
the
the lung,
size
right.
for the lungs.
Mhm.
So really, the individual weight itself, that might limit your donor selection to a certain, but you're put in for a weight range. So I don't think that it plays into how there's a lot of factors that get weighed, not just one thing. But patients are pretty sick going in.
All right. Thank you. I'm going to ask our participants, if you have any other questions, please put them in the Q&A and I'll go ahead and make sure and address them.
I can say that the wait time for lung transplants, of course, is all related to how high your lung allocation score is. But in general, when I see patients that come for referrals, generally they are sick enough to warrant an evaluation because their outside pulmonologist has seen their deterioration. And if we evaluate you and place you on a transplant list and you're in that median score range, I'm going to say you're going to wait anywhere from 6 to 9 months. However, if you become sicker and your score goes up, you'll wait a shorter amount of time. We do see a handful of patients that come pretty late in the game. We do evaluate them acutely. Sometimes they have to remain in the hospital, just like hearts do, and wait for their transplant. It's not the ideal way. You'd love to be referred early. You'd love to get your evaluation done and just put that in your back pocket, knowing that one day when I'm sicker, I will be a good candidate for transplant. That would be my Disney World goal to say that, you know, you come, you get your evaluation, and then you know that I have this in my back pocket if this is the last resort, but I'm healthy enough to wait and stay in the queue until I get sicker.
A question from one of our participants. Is there any general sense of how long the wait would be when one is on the heart list? And any sense of how the changes in status listing has made any sort of difference?
Have the changes in status as what?
Made
Sorry.
any difference in terms of the weight?
Um, yes, well, the weight has, the status changes have made a big impact on how sick patients are getting transplanted, I would say. If you can, I know you couldn't really read the criteria, but generally speaking in our region, like I said, status 1 and 2, status 3 patients generally have left ventricular assist devices in. So they've already been through surgery once for the device changes. Once they're a status 3, and it varies region to region. And honestly, the majority of our patients that have been in the hospital, because most of them have been status 1 and 2 over the last couple of years, I would say generally have waited anywhere from a week to 2 weeks in the hospital before they get an organ offer, up to about 3 months in the hospital. That again can depend on their blood type. You know, blood type O's, if you're an O person that's large stature, you know, tall, a big blood type O male waits longer. They definitely wait longer. But I would say on the average, it's been anywhere from about 2 weeks to 3 months currently in the hospital waiting. A couple of patients have been a little longer than 3 months. Again, that was size. Occasionally patients get sicker and we have to take them, put them on a temporary hold as well. So that affects how long they wait sometimes. But the status changes, I definitely will say patients have been sicker going into transplant on the heart transplant waiting list. So I would say status 1s probably get transplanted. They're at the top of the list, probably within a couple of weeks, generally speaking, or less.
Because the scoring system
Scoring
is to
system.
really, if you're sick, you get the organs first.
The sickest
Yeah.
patients get the organs first within, yes.
And I can tell you from a lung transplant perspective, my lung recipients, they don't feel good. Life does not feel good. Day to day, waking up, having trouble breathing to do just the most simplest of things. If we could give you a extra point for how sick you feel, but yet when we do your pulmonary function test, you're really not as sick as somebody else. It's hard to imagine, but you're stable but sick versus, you know, declining and needing high flow oxygen is so different. So we
Right.
understand, we know that you don't feel good and we know you can't breathe and you want your lung transplant yesterday. But when you're on our list and you're watched very carefully, you're right where you're supposed to be. You are being monitored closely. You're getting your scores updated so that when you are sicker, you are getting the score you deserve and you are getting the offers quicker because you are that person. You have moved up and you would be the one to get the next transplant. It's a very fair system. It works the way it's supposed to.
A little different for hearts. We don't actually have a score, but there's very specific, the card I showed you, there's very specific criteria for each status on the heart waiting list that we have to be sure everybody meets, and it has to be documented that you meet all of those criteria.
Thank you.